Hello and welcome to another NCGPA Live conversation, informative conversations about general practice in Nottingham City. I'm Dr. Andy Foster and today I'm joined by Tricia Gibbons. Let's bring Tricia onto the screen. Hi there, Trish.
Hi, Andy.
Good. So we have an interesting conversation planned today. We'll be exploring the challenges facing GP surgeries and practice managers, things that have happened over the last 2 years and things that are continuing to happen going forwards. But we won't just be talking about the usual negatives. Tricia really enjoys her job. That's really come through as we've been preparing for the talk today. So we'll be talking to Tricia about some of the positives about working with the staff and community as they go forward and navigate health over in PCN 5 in Nottingham City. So NCGPA is a federation with a membership of over 40 GP practices in Nottingham City. We hope that these NCGPA live conversations will be of interest to local practices and people working in or interested in primary care networks or GP federations, both in the city and more widely. We're aiming to have a fairly free-flowing podcast-style conversation on these topics today, which we hope will be entertaining as well as informative. So sit back, continue to drive to or from work, jog on the treadmill, do your ironing, and hopefully be entertained and informed as we have a talk about practice managers. So, Tricia, do you want to introduce yourself?
Yeah, hi, Andy. So Tricia Gibbons, practice manager at Tudor House Medical Practice, and we're part of the Bestwood and Sherwood PCN 5. I've been practice manager here for near on 9 years, working with Dr. Henry and Dr. Lloyd, my two partners, fondly referred to as the boys. But interesting fact is that we all met in prison. So it all started in HMP Nottingham around about 2005 when I started my first job for the NHS working in the prison healthcare. So I worked with...
How did Dr. Henry and Dr. Lloyd end up in prison,
In
Tricia?
prison.
What were they doing
Yeah,
there?
I wouldn't like to tell you what crimes they committed, but they have a specialist interest in drug and alcohol and substance misuse. So they've been working with Nottingham Prison for, I think, the best part of 20 plus years now, because they were there when I started 15 years ago. They continue to be the prison GPs in Nottingham. So we balance that work with their roles here, but it is completely separate. They work for the Notts Healthcare Trust, who run the prison healthcare. So
Right.
I worked there in a similar type job as practice manager.
Right, fantastic. And just for everyone's interest and for declaration of interest purposes, I'm Dr. Andy Foster and I'm an NCGPA board member and I'm acting Deputy Clinical Director of PCN1. I'm a GP partner in Ball and Top Valley, another part of Nottingham City. Really interested by this story, Tricia. So you're met in prison when you had a role within the prison service and they were providing services into the prison. But that's obviously not the end of the story. So what happened next and how did you come to be their manager?
Yeah, so actually my role was, we work for the NHS because the prison service health is provided by the NHS. So I worked for them. After about 7 or 8 years, I moved out of the prison and went over to work for the secondary trust for trauma and orthopedics in the hospital. Did about 12 months working for them, and then Dr. Lloyd contacted me to say they were looking for a new practice manager and was I interested. So actually becoming their practice manager was my first ever job in a GP practice. I'd never worked in it before. So the learning curve, as any new practice manager would tell you, was a complete trajectory of straight up. But yeah, really challenging. And here I am 8.5 years later, and it's probably the best job I've ever had or ever will have.
Wow, and that's quite an endorsement for the role, actually. 8.5 years, that's becoming quite a long time now. I guess I'm sure you've seen lots of challenges over the time. Just wondering what sort of challenges are you facing in your surgery at the moment? We'll talk about more general challenges in a minute. It might actually be worth telling us a little bit about the composition of your surgery and then what particular challenges you might be facing at the moment.
Yeah, so one of the challenges, obviously, is recruitment. We're currently advertising for a 4-session salaried GP, and to date, absolutely no interest whatsoever. So we have a varied multidisciplinary team. So we have got a good complement of nurse practitioners, nurse prescribers, and we've got our PCN roles as well. But actually, we do just want another GP as well. So struggling with recruitment on that. Recruiting admin staff, reception staff has become a real challenge over the last sort of 2 to 3 years. You would have previously put an advert out and been inundated with interested candidates, but it does seem to get thinner and thinner with each advert that we put out. But we've managed to recruit some really good staff over the last few months, and it's thinking a bit differently about not just taking staff that are already working in general practices or even within healthcare. Is that there's some great reception and admin staff coming from sort of outside of the NHS.
How did you find those people, Tricia? I'm sure there might be managers watching who are keen to learn some innovative approaches to recruitment because it is so challenging. Any tips?
So obviously, again, massive learning curve for them because they've usually only sort of seen the NHS from the side of being a patient. So I guess it depends what their level of medical knowledge is as a patient. But certainly one of my more recent recruits is a youngish girl, and I think I'm fairly IT savvy, but she blows me out of the water with, what she was showing me on System 1 a week into her sort of, new job. And the fact that we rely more and more on technology to help us do what we're doing. So the younger generation coming through, and even some of the, older generation who have a real interest in technology are flying around these systems. And the systems knowledge is a big thing.
Absolutely. I know we've had some apprentices over the years, and they often bring quite a lot of IT savvy to the team, and can sort of, just in terms of soft skills, just kind of upskill everybody and show them how to better use their IT resources, which is always really, really welcome. What's your sort of patient kind of population like over at your practice, Tricia?
Yeah, we've got a very sort of split population, but we don't have any particular pockets of anything, if you like. So even within our PCN, we've got practices that have got a huge elderly population or a much higher deprivation. We are very straight down the road, really, in terms of a bit of a mix of everything, which makes it quite interesting from both a clinical perspective for the practicing clinicians to the reception and admin staff that we're dealing with. Probably more and more non-British patients more recently. We've probably got a reasonable amount of Eastern European, but again, not as many as other practices. So we've got a little bit of this and a little bit of that and a little bit of everything really going off.
So are there any other big challenges that you guys have been facing, either particular to you, or perhaps things that you think people might be experiencing more generally in the NHS at the moment?
So obviously, without mentioning the C word, COVID obviously has been a huge challenge for everybody, but it has also given us opportunities to look at different ways of working. So even this week, I've been faced with 2 of my clinical team being off with COVID, which 3-4 years ago would potentially have made a huge hole in my service provision for this week. But actually, we've just defaulted to them working from home, delivering telephone triage, telephone consultations, and all the other clinicians are picking up the face-to-face appointments. So it's something that we've had to really change the way we're working. And each of those challenges gives you the opportunity to look at doing something different rather than just thinking, no, we're just not going to be able to do that.
Yeah, and I know I've been working it from home for the first time this week, actually, as well. Finally, COVID caught up with me this week, so I've been working from home. Found it quite challenging, actually. We've been doing quite a lot of telephone triage work for quite a long time, and particularly through COVID. But I've always had that option of being able to see people in the surgery later on in the day and having
Yeah.
a certain proportion of face-to-face appointments. So going completely remote, I found quite challenging, actually, kind of having that option taken away from me in terms of how I consult, and having to bring people in to see somebody else. I found quite difficult
And I
to handle.
think all our clinicians would probably agree with you there, Andy, is that having that safety blanket of knowing that you can bring them in. So we just have to move to a model of we've got other clinicians on site that can offer face to face. So if one of those working remotely does need somebody to be seen, we can bring them in to see a different clinician. So it's having that balance and shifting your sort of appointment provision around to be able to do that.
Yeah, it feels like the change in the way people see their GP over the past few years, accelerated by COVID, has been quite a big story and quite a big issue for the general population over the last few years. I just wondered, what's your experience been of sort of patient satisfaction with getting an appointment, getting the type of appointment they want? What's been your experience of that?
I think honestly, Andy, generally we've been quite good and we've been quite lucky. Throughout COVID, particularly, we didn't get hit too badly at any particular time. So we never had a point where we couldn't deliver any appointments. We never stopped delivering face-to-face appointments, despite the sort of media populating the myth that we did. So we never had those challenges. And what we actually found was that the delivery of telephone appointments was something that our patients have really embraced. So that's a model of working that we will continue to offer. And that can be based on patient preference or clinician preference, but does allow us to sort of continue to be able to offer a service at all times. But certainly, yeah, telephone and face-to-face, a hybrid model seems to be the way forward for us, definitely.
Yeah, I know we found that probably about half or even more than half of people actually seem to quite like the telephone appointments. They find it quite
Yeah,
convenient. A lot of people do work. A lot of people are quite happy and in fact prefer to speak to somebody first before seeing if they actually need to come down. Take that time off work, take that bus or that
yeah,
that car journey to come and see us. So it's been really interesting. I've found the the sort of perception piece in the media been quite an interesting challenge over the last few years. And for me, it feels like it's more about
mm,
getting the right person in the right appointment for them, and it's getting that fit
yeah,
right person in the appointment that's the challenge, rather than necessarily going back all to face or keeping it majority telephone. It's been a really interesting
yeah.
puzzle to try and get that
But in
right.
talking about that, getting the person into the right place at the right time, and that is that we follow the NCGPA signposting model, which we bought in about 4 years ago. I saw something yesterday that reminded me that actually it was more than 4 years ago, and I can't imagine doing anything different now, of actually just asking the patient the brief reason for their appointment allows us to make sure that we signpost them to the most appropriate clinician in practice, but also gives the opportunity to signpost into self-care routes, or whether it's a self-referral to physio or a self-referral to midwife, whereas previously a lot of those contacts might have actually resulted in an appointment that was actually then really quite unnecessary. So it's a model that really works for us.
Yeah, gosh, that was a few years ago, wasn't it? I was quite
Yeah,
involved in that.
yeah, yeah,
That was quite a lot of fun actually. Um, Yeah, and I remember before then, I remember having a lot of what with hindsight were quite pointless
mm,
consultations with people who actually did just need to see a physio, but
yeah,
they had to go through a conversation with me first in
yeah,
order to get there. So I'm really glad that there's alternatives to that now. And yeah, reception team and practice admin and management teams do so much more now than they
mm,
used to. Tricia, I was just gonna ask you a question about uh, I often strikes me that it might be quite isolating being a practice manager, sort of not being sort of fully part of the clinical team, not being
yeah.
necessarily fully part of the rank and file admin team, if we use those terms. You're kind of somewhere in between in quite a unique position.
No,
How do
no
you find
man's land. No man's land. Yeah. Um, I think having your network of practice managers is absolutely essential. And whether that's just a small network within your own PCN, or whether it's a wider network within the city or the county, wherever you are, making sure that you make time to connect with those people via the meetings that are there. We have practice manager meetings and LMC forum meetings, and it's always the same faces that are on there. And a lot of people might say sometimes, and I've done it myself, I've been tempted to say, oh, I'm too busy to go, or no, I really need to do this. But actually, those times are really valuable in terms of things that you'll pick up from other people, and actually also just knowing that there are so many others in the same position that we are, and that actually you're not failing, and that we're not failing as managers, because actually everybody is facing the same challenges that we are. So it's good to know that there are lots of others in the same boat with us.
Yeah, good. And I was going to ask also, a lot of people draw support from WhatsApp groups, and WhatsApp channels, and that's often been a bit of a go-to to replace some of that face-to-face networking that
Mm.
we've maybe lost during COVID. You must be in loads of WhatsApp groups and things like that. Is that helpful, do you think, or how do you manage that?
Yeah, I think over COVID again, we all sort of set up and joined lots of COVID WhatsApp group, but we actually set up our first practice manager WhatsApp group when we had the NHS cyber security attack about 4 years ago. And again, we were finding that we were talking to our friend that was a practice manager and they knew something we didn't. And so we set up a little WhatsApp group in our locality, which was then the old Norcom board group, and that practice manager WhatsApp group still is going today. So it reaches into PCN 2, 1, 5, and some other PCNs. So we all share knowledge. We ask each other quick questions that don't necessarily need an email. It'll be things like, is anybody else's phone system not working? Has anybody's system one dropped out? And somebody quicker will then respond and say, yes, it's a whole national problem, or actually, no, we're all fine. And then you know that you've got to get onto NHIS or somebody to sort your systems out. So it's just a really quick win. But the danger of WhatsApp group is that they do become a bit OTT. So we've then set up within the practice one that's just a broadcast list, which only me and the partners can send messages from. And we use that as our business continuity communication cascade. So it's nobody can reply, but we can push out really important messages really quickly to everybody.
Yeah, that sounds like a really good idea, actually, the broadcast group, because sometimes WhatsApp channels can become a little bit congested with general chit chat, can't they? And that can cause some people to switch off the notifications or just kind of switch off and log out from that chat, which isn't
Yeah.
always what you want. Tricia, my practice manager always seems really, really busy, and I'm sure they are really, really busy, but they get quite a lot
Mm.
done. I'm often astounded. You must need really good time management skills. I'm just wondering if you have any particular tips, which you might not have, but
Mm.
how can you be productive as a practice manager?
I think having obviously a bit of structure to your week, whether you use electronic diaries, manual diaries, to-do lists, reminders, whatever you do, whatever works for you. Everybody's very different. Sometimes I'll have a hybrid of a paper diary or an electronic diary. At the moment, I'm focused on my electronic diary because that's where everything seems to go. Setting yourself reminders when you're getting deadlines that somebody flagged in a meeting yesterday about the SDS patient engagement document's got to be back in a couple of weeks. So just little prompts like that, making sure that they're in your diary, making sure you don't miss those important deadlines. And yeah, I have diary cards that come out monthly that tell me to do different things and being organised. But the other thing is that you could just spend all day managing your emails, and you've got to switch off from that, and you've actually got to protect a bit of time and say, no, I need to spend this afternoon rewriting my business continuity plan or doing that audit or doing that return. So you do have to try and be a little bit structured, but it's very difficult not to get interrupted. And I know a lot of practice managers are now having maybe one day a week where they work from home so that they get that balance of actually, I'm available, but actually on that day that I'm working at home, I'm going to get my head down and get on with those policies, procedures, audits that need a bit more time. And then when you're in the practice, you are always available. So it's drawing that line between, yes, I'm available, but actually, can you work that out for yourself? And just drawing on all the tools that are available out there to help you with things, and having a good deputy that you can hand things over to, and empowering your team. I think that's what I've seen a lot of the times with practice managers is when you speak to them, they do everything. And it's like, haven't you got somebody that you could hand that over to, that you could train and empower them to do that? So that structure around you is so important to survival.
Yeah, oh, they're really fantastic tips. I think I see our manager deploy quite a lot of those in practice, and they've been there for a few years. Actually, I think you're right. They've really developed the team, I think, while they're
Mm,
here, and really kind of invested time in helping the rest of the team grow and develop their own skills and capabilities to enable them to do more, and then the manager can concentrate on where they're delivering value.
mm,
Um, Trish, it's a really big role. I've seen it expand. I've been around for about 10 years, and I've really seen the practice
mm,
manager role expand. We've had CQC come along in that time. It's much more important to have your policies up to date. HR seems to have got a lot more complicated, as have some of the contracting and financing
mm,
requirements. There's just so much going on, and I've started seeing different types of managers at different places. There are general managers, business managers, HR managers.
Mm.
Um, how do you feel about that fragmentation of the role? Is that a positive thing? Is that a negative thing? How do you feel about
I
that?
Yeah, I think it's interesting, and I think, Andy, in the bigger practices, you do see much more sort of division of those roles and very specific roles. My practice is only just under 7,000. We are the average size practice. So I focus very much on the business, but then I have an operations manager that does a lot of the other stuff. But I have to get involved in the other stuff as well because we just don't have all those other managers. I think what I've started to really realize and embrace is that there are massive risks and challenges if you don't get those things right. So your health and safety, your HR, your compliance, your CQC. So again, delegating within your teams to making sure they're all done properly within your managers, but also embracing some of the consultancy services that are out there that will do a lot of these things for you. And they are the experts in HR, they are the payroll experts, they are the health and safety experts. And some of them provide services that aren't unaffordable. And what you need to balance is that whilst it might cost you £100 a month or £50 a month to engage those services, if you get them wrong, the costs will be horrific.
Yeah, absolutely. And also, it's not just the time doing them, isn't it? It takes quite a lot of effort to train and remain current
Yeah.
in being a proficient HR practitioner or a proficient
Mm.
payroll administrator. And, maybe maybe your time can be spent better doing other things for the practice that you can only do from
Yeah.
that seat of the practice manager. So, yeah, I really agree that it's important to be open to outsourcing certain elements as well. Yeah.
Yeah.
Tricia, I was going to just a kind of change of direction because I want to talk to you about primary care networks as well as a
Mhm.
lot of other things as well. And a good way in might be just to talk about physicians associates because it's been something that's been a little bit controversial. There's been a BBC
Yeah.
Panorama program about it recently as we're recording this. And I know that in PCN5, your primary care network and in your practice, you've got quite a lot of experience working with physicians associates. So I was just wondering, you might need to just say very briefly a little bit about what the role is, and then
Yeah.
how have you found having physicians associates, in your practice and in your primary care network?
Yeah, absolutely happy to, really fly the flag for PAs. We kind of hit the jackpot with the one that we were allocated from our PCN last year. He was fresh out of PA training school, so they do a science degree, and then I believe it's a 2-year add-on to be a physician's associate. So they don't well, ours certainly doesn't prescribe. I do think that non-medical prescribing is something that's being considered down the road for them. But they can assess, they can diagnose, and they can arrange a treatment plan for a whole range of um, illnesses and ailments, and support the GPs in managing patients. So ours came to us last August, fresh out of university. So yes, there's a lot of supervision, and that was the big thing that Panorama picked up on. So although they didn't sort of particularly say that physicians associates aren't good, what they picked up on was that physicians associate need supervision. So we have protected time each day for that, our GPs, for the physicians associate to be able to discuss every single patient that they see. So we are now nearly 12 months in with our physicians associate. He's growing in confidence. The patients are happy to see him, but I think the Panorama article could be quite damaging. So I was sort of expecting a little bit of pushback this week when we're saying, because we're always very transparent with our patients. When we book an appointment, we will always say, that's with Dr. Lloyd, that's with Dr. Henry, that's with David, he's our physician's associate, that's with Simon, he's our nurse practitioner. Because if you don't give the patients that information before they come to the practice, when they then come in and realise their appointment isn't with a doctor, they can be a bit blindsided and can be a bit, oh, I don't want to see somebody else. But you have the opportunity at that appointment booking to sort of explain the physician's associate and what their role is. So with the right supervision, they are a huge, important, integral part of the role. And as we all know, recruiting GPs is nigh on impossible. So we have to embrace different ways of working, different models of providing the service safely, and physicians associates will be a big part of that going forward, no doubt. I wouldn't hesitate if we didn't have a PCN physicians associate, I wouldn't hesitate to try and recruit one directly for the practice in the future.
Yeah, it's a really positive things I'm hearing there. And actually, when I listen
Mm,
to other people who work in your area in PCN5 in Nottingham and in PCN6 who've also embraced the physician's associate roles, I'm hearing really, really positive
mm,
things about the roles, actually. So I think that does look like a really positive development for the future. We perhaps need to start thinking about it in our primary care network up here in Bulwell and Top Valley.
definitely, definitely.
So physicians associates is one of the primary care network additional roles reimbursement scheme roles.
Mm.
Primary care networks in these roles are an area where there's actually quite a lot of new funding, quite a lot of new roles and new people moving into general practice, but working a slightly different way in that they're employed by a primary care network, sometimes through federations like NCGPA, to work across a group of practices, which can bring its own challenges as well. What's been your more general experience of the primary care network ARRS roles? How's it been going in your area?
Yeah, so some real positives and maybe some sort of less positives. So we've got fantastic prescribers, clinical pharmacists, not prescribers, clinical pharmacists, and we've got social prescribing link workers who are now post-COVID really visible in the practice. They're here 2 to 3 days a week. We know they're coming. We know if we've got a patient we want to refer a medication query to, or just a patient that doesn't really fit in any pathway for clinical um, treatments, that actually we can discuss them with the social prescribing link worker. So we've got Lucy and Elena, and we know they're coming in, and that's really nice. And we're developing really good relationships with them and can signpost people to them. We've had slightly less success with the physios in our PCN, that we were allocated a physio earlier in the year, but unfortunately the contract that the PCN had with the physiotherapy provider, they've had a few issues with that, and I think they're looking for currently a new provider. So that was great. To think that we'd have that robustly going forward, a first contact physio in practice again would be massive. If we could get that nailed down, it would be amazing. But we had it for a very short period of time, and it was like, that's great. But then unfortunately it fell over. PCN are working, the manager's working really hard to try and source us another physio, and mental health practitioners, because I'm sure, Andy, you see this now, is that mental health needs are huge, and the waits to get into mental health services, particularly maybe for some young teens struggling to get into the services, that actually we've sort of put our hands up and said, actually, if there was a mental health practitioner available, we'd actually love to have one of those in practice.
Mm. Yeah, so we've had a mental health practitioner in our area that's been really helpful and successful. Although they've currently left the post and we're waiting for
Mm.
to recruit another
Yeah,
one. It sounds a similar story to your first contact physios, but we've
yeah.
had quite a lot of success with first contact physios. We've got we we contracted a number of full-time equivalents, which I think has helped us keep sort of continuity,
Mm.
because certain individuals have come and gone, but the service has never had to step down to zero, which I think is
Okay, that's really
really,
good.
really, really, really helpful. You've mentioned, getting people into practices and with the staff and with the patients together. Any other things that you think are kind of key for primary care network roles to be successful? Any other thoughts or
So,
tips?
yeah, I mean, obviously we have our regular monthly board meetings, and we're trying to set up regular practice manager meetings, although they seem to be sort of getting off to a false start, but we'll get there. We've got a great proactive new network manager. So I think things will definitely move forward in that direction. Dr. Lloyd and I attend the monthly board meetings on behalf of the practice. So we're starting to really get to know the other GPs and practice managers in our network, which really helps as well. And we're sharing lots of knowledge, trying to do sort of joined up working. We did COVID vaccination clinics as a PCN at the end of last year, which is the first time we've ever sort of run something on such a scale collaboratively. And we ran our clinics from the Hucknall Road Medical Centre every Saturday, and we drew staff from all of the practices within the PCN network. So it was great to actually go and work with staff from other practices and talk to them about how things work for them. And it was, yeah, it was a brilliant service for our patients. It was very successful, and the managers took it in turn to sort of run the clinic each week with a GP acting as the clinical lead, and it was very successful. It was very efficient, and it was a great service for our patients, and yeah, a great opportunity for us to work collaboratively.
Yeah, it sounds like a real success story there. And I think that the COVID pandemic has been a bit of an accelerator for primary care networks in some respects,
Mm,
in terms of putting a real imperative there for people to work together to deliver something that's really needed for the community, like vaccination clinics or hot clinics. And I guess in some ways, my experience is it's slowed some things down, like the deployment of the ARRS roles and the getting them out physically
yeah,
to practice as well. So it's all been a bit of a mixed bag. Tricia, I also wanted to ask you about just your experience of working with the federation, because that's, I guess NCGPA, we are at NCGPA Live. And in some ways, federations have had a strange few years with the advent of primary care networks, as having sort of more prominence now, within the NHS, but federations still being very much around. For example, in Nottingham City, NCGPA is sort of the biggest employer of the additional roles reimbursement scheme staff provided to primary care networks and practices, for example. Um, and I was just wondering, what's your experience been engaging with the federation, and do you have any tips for the federation to help either deliver, their services better or to engage with you better?
yeah. Yeah, I suppose the first thing to say, Andy, is obviously NCGPA has always provided our extended access hours in Nottingham. So it's always been great as practices that's been our security blanket. We've always known that that service is being provided for us. So we haven't had to tap into staff to be starting to work till 8 o'clock at night and weekends. So it's been brilliant that that's been provided for us. There have been difficulties at times with accessing those appointments. But again, I think the Federation's been quite responsive to that in the last 12 months, and has now sort of put processes in place to protect ring fence appointments for each PCN, which certainly has benefited us. So that's great. One thing that we'd love and would really push for would be something a little bit closer to home for our patients, because the service being in the city centre, I know it's obviously a great location for many, many reasons, but it's not always a tempting offer to a patient to say, get yourself into town for 7 o'clock on a wet, windy night. So something a bit more local in the Bestwood Sherwood area would be amazing.
Cool. I mean, hopefully that'll be coming with, with network hours and the change into the extended access contracting. I think we're all in the process of going out and asking the patients what
What
they
they
want
want.
and what would work for them in each of the primary care network geographies. So hopefully that will lead to some more of these sort of spokes, where PCNs, and their populations choose that that's what they need. So yeah, that's really good to hear. And thanks for being honest. Part of NCGPA is about listening, to what
Yeah.
people say and trying to deliver. And so it's a tough job being a practice manager. It's been a tough few years to be
Mm.
in general practice. Um, how do you go about sort of protecting your well-being, and how do you suggest other practice managers do that?
I think I know I've already touched on it, is having that team around you, empowering your team to deliver things and not necessarily rely on you for everything. Having a deputy, I think even in a small practice, a deputy is essential, because otherwise the practice manager's kind of got to be available almost 8 till 6:30 every day, which is not reasonable. Taking your time out, not working silly hours every day, talking to your partners if the workload is becoming too much. I think for me, that's part of my survival, is that my partners are incredibly supportive and allow me to um, manage as I see appropriately. I think I hear some horror stories where a practice manager might want to do something, and it's whether it's taking a member of staff through a performance process, or whether it's recruiting a new member of reception staff, and are having to sort of come up against barriers from partners that maybe don't want to spend that money. And I'd push practice managers to sort of look at the bigger picture, that an extra 5 or 6 hours receptionist might look like it's going to cost you a bit more, but look at all the things that they could do. Look at the extra recalls that they could get people in. Look at the extra quaff income they might be able to bring you. Look at the extra pneumococcal lists that they could phone patients, shingles patients that they could phone people to come in. So it's looking at those bigger pictures, and my partners allow me to do all those things without putting those barriers in the way. So having open and honest conversations with your partners and building that trust is obviously huge, because then they allow you to manage the practice. And my network of practice managers, my huge shout out to my Nottingham practice managers, and even I'm on a national practice managers Facebook page, and I think in COVID they were invaluable, that we could all fire questions out on them, we'd all respond, or if we're having a bad day, there's a lot of love from across the country, so we know we're all sort of feeling the same things. Having those networks to support you is invaluable. And the LMC helping out, supporting us, roving PM scheme for practices that are struggling. There is a lot of support out there, but it's sometimes getting your head out of where you're at to be able to say, I need some help. Talk to your practice manager colleagues.
Yeah, absolutely. And I'm just sort of hearing what you're saying about the LMC actually as well, because if there are managers out there who are a little bit disconnected, not quite sure where to start, it always strikes me that's quite a good place to start
Yeah,
building your network. I know a lot of the workers who work with practices from the LMC tend to be ex-practice managers. They tend to
yes,
be quite well networked
yeah,
in to the other managers. So actually, it's a really good place to turn if you're feeling a little bit out of your depth or struggling to settle as a new practice manager, or has always struck me as such. Um, I was in when we're talking to other GPs and GP partners, a big challenge or problem that's coming up is succession planning. A lot of GP partners are
mm,
potentially older, or they're coming towards the end of their careers, and practice is really worried about succession planning for GP partners. People also talk about succession planning for practice managers, because a lot of the
mm.
prominent practice managers out there may not be out there for another few decades, and it can be difficult for practices to see where their next new replacement practice manager comes from. Have you got any thoughts about these succession planning challenges around planning?
Yeah, I think you're absolutely right, Andy. I think you hit the nail on. There's a lot of us practice managers are sort of looking sort of the other side of the fence now in about 5 years' time, sort of how, but we want to also think about how we can sort of get people into the roles. I think probably a couple of things is the NCGPA ran a course in Nottinghamshire a few years ago called the Step Up to Practice Management, and gave people that were already working in practices the opportunity to go on some courses and workshops and talk to them about life as a practice manager and the different roles that they would need to be sort of capable of doing it. So that was some real hands-on practical training effectively for people that were already in the NHS. But equally, there's a lot of practice managers now that I know that have come from non-NHS backgrounds and come straight in as a practice manager. Banking seems to be a very popular one. That was my background for nearly 20 years. I know a lot of practice managers that are ex-bankers, and one thing that the banks were always very good at was training their staff, and we got lots of training in customer service, managing complaints, coaching staff, managing staff, all really key transferable skills to bring you in as a practice manager. And I think, again, whether you've got a deputy manager or an operations manager or an assistant practice manager, whatever you want to call them, share with them. Don't keep hold of all your knowledge, involve them in as much as you possibly can, so that they're exposed to. So we talked earlier, didn't we, about having the separate roles, but actually there's some blurring of roles is not necessarily a bad thing, because otherwise, when you might be an operations manager in one practice and jump to a practice manager in another practice where you have to do everything. So just think about opportunities there to sort of share that knowledge and learning. But we all sometimes get so busy doing the day job that we kind of don't want to step back and do those things, but it's really important that we do.
Yeah, that's good. So I'm sort of hearing, grow your own a little bit. Think about looking, elsewhere to other sectors when you're recruiting, and that maybe the system has a role in funding and providing training opportunities to make sure that people learn those essential skills. Yeah,
Definitely. Affordable and accessible training for all practice staff really is essential. really.
Yeah, that's good. Do you actually, you make it sound a little bit more positive, and like actually, meeting that succession gap is probably doable. Provided
Yeah.
we give it the right attention and perhaps a little bit of funding and system attention there.
Yeah.
Um, our our practice manager is a partner as well, Tricia. I'm just wondering if you've ever been tempted to ask to become a partner at your practice or go down that route. Is that something that's ever tempted you?
No, to be honest, no, it never really has. It's I love the autonomy that my partners give me. We have an excellent relationship. They're super supportive when I want to go off and do NCGPA lives, or I went off to help manage one of the COVID vaccination centres last year for 7, 8 months, and I can do all that with the security of knowing that my salary is safe. Essentially, at the end of the month, my partners here are a very 50-50 partnership, so I'm not quite sure that how my role would necessarily fit into that. And I guess for a lot of practice managers, if they don't have that autonomy, there might be maybe more of an appetite to become a partner to get you that autonomy, that you'll have that say. But I feel that my partners treat me as a partner whilst being a salaried. So I don't really feel that I would get any massive benefit from being a partner in my practice, but I could imagine in other practices it might well be an appropriate way to do it. And potentially practices where there's lots more partners, I can almost see the practice manager having that voice as a partner as opposed to a salaried might be more helpful.
That's interesting perspective. It sounds like you've got a lot of the benefits of being a partner in terms of the trust and relationship, without some of the downsides. So it doesn't sound like
Yeah,
a bad deal there. But you're right; it's different in different practices, isn't it? And with different people.
yeah.
So I guess that brings us towards the end of this conversation. We always ask people at the end, what do they think that the audience should do next? A call to action, if you
Call to
like. Is there
action.
anything that you think people should do next after hearing this?
My best bit of advice, ignore the media narrative. The media narrative is that GP practices are all sitting around doing nothing. We're not. It's a really interesting place to work. One of the best parts of my job is talking to patients, and that's even those patients that are calling to complain, because I like to listen to them. I like to listen to what they've got to say. So don't listen to the media narrative. Life in general practice is really, it's challenging, it's busy. You don't come in and you don't twiddle your thumbs, and each day is different. And that is probably one of the best parts about the job, is that no 2 days are the same. And if you're interested in a career in general practice, I would absolutely encourage anybody to do it. Think of your own personal resilience, make sure that you're ready for that, make sure you're ready for the influx of everything that gets thrown at you, and yeah, just go for it.
That's really, really positive. Tricia, if someone wants to be a practice manager, where are all these jobs listed? How would people take the next steps towards becoming a practice manager? Is it the LMC website? Where are the jobs?
Yeah, various places. LMC website is one of those. So obviously in Nottinghamshire, it's just Notts LMC, and there are a variety of jobs on there. A lot of practices advertise on NHS jobs, but I think any practice manager would sympathise with me by sort of saying it is the most clunky and horrible system to put an advert out on. They updated it last year, and it was probably one of the worst updates possible. So a lot of practices have now gone down the route of Indeed, but there are also companies out there, sort of without advertising. First Practice Management, Practice Index, they run recruitment programs on behalf of practices for practice managers. So you could always have a look on their websites and see what they're recruiting for.
Good. Well, that all sounds really, really positive and a nice note to end on. I'd like to thank you very much, Tricia, for joining us and sharing all of your experience and your positivity with us, which is really, really valuable. And just to thank people who've stayed with us to the end of this hopefully interesting conversation. And thanks very much for staying with us and supporting the podcast and this broadcast.
Yeah, thanks,
Thank you
Andy.
very much.
Yeah, it's great. Thank you.
Good. So here's just a screen with some information if people want to contact NCGPA. If you've got any suggestions about topics that we should cover, if you want to appear and be interviewed, then just get in touch with the team here at NCGPA. And I guess we will end and people can go off and enjoy the rest of their day. Thanks, Tricia. Bye-bye.
Bye.